visible to you all? And is it live now? Yeah, think, yeah. Hello, Mega Prasad. And this is an IBQ spread series where we'll try to cover 25 most important images. My focus today would be on the GI imaging and some interesting cases and interesting images that is related to radiology of GI imaging we'll be trying to do. We'll also do some nuclear scans and some angiography images also. And we'll do this in focus that we cover a lot of images in a very short duration of time. We'll keep this session very brief, 25 minutes to 30-minute session, but we'll try to cover a lot of images in this session. Okay, so just I'm waiting for everybody to join in. All of GI imaging will be trying to do. We'll also. Okay. So just give me a quick yes if you can all hear me properly. Shall we get started? Yeah, just 1 minute, we'll get started. Okay. Okay, so let's start with the first images. Now, we have to be time bound, right? So let's get started with this thing. Good evening, Mayur, Hemant, Priti, Biswas, Tejasvi, Mithilesh, right? Let's get started. Look at the first one. What do you think is the first image showing you? Uptake in the brain is seen, and you're also seeing that the bones are black. You can see the humerus, the femur, the bones are black. What do you think is this first image showing you? What do you think is this first image? What is this first image showing you? The uptake is seen in the brain, so this must be 18 FDG that is given to you, right? The glucose goes into the neurons, and the bones are black. This must be MRI. So this is PET MRI, PET MRI. And what about the next image, guys? What about the next image? Do you see uptake in the brain? Yes. And how are the ribs? How is the pelvic bone? How is the femur? It is what? White. Very good. Hemant, this is PET CT. This is PET CT, PET MRI and PET CT. Now, having done this, you tell me the third image. You tell me the third image. You get that orange tinge, and in the bladder, you are seeing the contrast. You are seeing the lesion in the cervix. Also, there is a lymph node that is seen by the arrow. So you can see here, there is a lesion in the cervix, and there is also a uptake in the lymph node. What do you think is this image now? How are the vertebra? Look at the vertebra. Look at the sacrum, the coccyx. Is it white or black? What do you think is this? How is the bone? Bone is white or black? Is it white or black? You tell me that much. Is the bone white or black? The bones are black here. The bones are black. So bones are black means what? MRI. So this is again a PET MRI. So it's important to look at the bones. See the bones. Are they appearing? The cortical bone is white or black? If the bones are black, that would be a PET MRI. The PET MRI. Are you okay with the first slide? Are you all clear with the first slide? Is this clear? Shall we go to the next one? You can pick up on the day of exam, which is PET CT, which is PET MRI. Look at the bones, right? If they are showing a white area, the cortical bone is white, that would be CT scan. If the bone is black, that would be MRI, right? So let's go to the next one. There are some digital subtraction angiography images we'll try to cover. Look at this. The contrast inside the blood vessels is black. So when the contrast inside the blood vessels is black, and you can see the catheter inside the aorta. This digital subtraction angiography or a catheter angiography, this is showing a catheter angiography or a digital subtraction angiography of abdominal aorta. Now, what do you think is this? I hope you can see these are the renal vessels, right? Showing the blush in the kidneys. So this is the aorta that you have showing the renal vessels, right? So this is digital subtraction angiography of the abdominal aorta. What about the second image? What do you think is the second image? What do you think is the second image here? What is this vessel? Which is more horizontally oriented, right? So you can see it going horizontally. You can see a main trunk and three major vessels coming from it. The common hepatic artery, the left gastric artery, and the splenic artery. This is the digital subtraction angiography of celiac trunk. This is of the celiac trunk, right? Digital subtraction angiography of celiac trunk. You see the three branches coming from the celiac trunk, the common hepatic artery, the left gastric artery, as well as a splenic artery, right? The tortuous vessel going towards the spleen, that is the splenic artery. This is digital subtraction angiography. Again, the contrast inside the vessels is black. So this is digital subtraction angiography. Of which vessel is this? Now, what do you think is it? Superior mesenteric artery, abdominal aorta, inferior mesenteric artery. Which artery is this? If you look at the digital subtraction angiography image, this is showing blood vessels originating on the right side also, on the left side also. In superior mesenteric artery, the small intestinal vessels, the jejunal and ileal vessels, they arise from the left, whereas the colic arteries, the right colic artery and the middle colic artery, these arise from the right. So this is digital subtraction angiography of superior mesenteric artery, Are you following? So you can see all these vasa recta telling you it is going to the bowel. It is supplying the bowel, right? So it is a artery of the midgut, the superior mesenteric artery, having the small intestinal branches coming from the left side and the large intestinal branches coming from the right side. Look at this image now. This is also a digital subtraction angiography image. And this digital subtraction angiography image is showing branches only coming from the left side. You don't have any branches coming on the right side. So this is a digital subtraction angiography of inferior mesenteric artery, right? You're having branches only on the left side. And what are the branches of the inferior mesenteric artery? You see this vessel, this is the left colic artery. This is the sigmoidal artery and the superior rectal artery. Sigmoidal, and this is the superior rectal. So these are the branches of the inferior mesenteric artery. So the inferior mesenteric artery gives rise to the left colic artery, the sigmoidal artery, and the superior rectal artery. Whereas the superior mesenteric artery gives rise to the right colic artery and the middle colic artery. How to differentiate? Is it IMA or SMA? IMA gives branches only on the left side, whereas SMA gives branches both on the right side and the left side. Is this clear, all of you? I hope this is comfortable for all of you. And you can see this continuous, anastomotic branches supplying the bowel, right? So you continuous vasa recta are seen that are supplying the bowel loops, right? So that is how you know these are the arteries supplying the bowel, right? Let's go to the next one. What are these images? The contrast inside the blood vessels is white. The contrast is white. Contrast is white. So this is not digital subtraction angio, right? And how is the bone? The skull is appearing dark. So when the bones are black and the contrast is white, these are MR angiography images. So this is MR angiography. And this MR angiography, what is it showing? You can identify the circle of Willis. I hope you can know this is the basilar artery, which is dividing into posterior cerebral arteries. This vessel here, this is the internal carotid artery. This thick vessel is the internal carotid artery. And the red arrow, this is pointing to the right MCA, middle cerebral artery. So this is the left MCA and the right MCA. And these vessels here are the anterior cerebral arteries. So I hope you can briefly identify the vessels given on your exam. This is the MR angiography image showing the circle of Willis. And these are coronal and sagittal images of MR venography. So when you see the dural venous sinuses, not the circle of Willis, when you're seeing the dural venous sinuses, you call it venography. The contrast is white and the blood vessels, they show the opacification, right? The dural venous sinuses are seen. So you call it venography, dural venous sinuses on a coronal and a sagittal image. Let us try to label few of them. This is superior sagittal sinus. It is going towards a confluence of sinus. And from there, on either side, you're getting the transverse sinus, which is becoming the sigmoid and which follows into the internal jugular vein. I hope you can manage this. This is a sagittal image showing the same thing. The superior sagittal sinus, the inferior sagittal sinus, the straight sinus, right? Going towards the confluence of sinuses. So just pick up the image. This is MR venography images. Now let's come to something, some cardiac images. Let us try to cover a few cardiac images. Let me see how many of you will get this right. What do you think is the first image showing you? What is the first chest radiograph showing you here? Can you look at the first one and tell me what is this first image showing you? What is this? Is it tetralogy of Fallot? Is it Epstein's anomaly? Or is it TAPVC? Or anything that comes to your mind? What is the first radiograph showing you? Waiting for your answers. I hope you can see the cardiac silhouette is increased on both sides. It is not just increased on one side, it is increased on both sides. So such appearance is called as leather bottle or money bag appearance. Money bag. So when you see the cardiac silhouette increased on both sides, right, on the right side also and the left side also, this is not a chamber enlargement. This is pericardial effusion. Pericardial effusion. If they give you Bextrad, trauma patient with Bextrad, the same image, you can also answer it as cardiac tamponade. We're correlating it clinically, right? So pericardial effusion, you are seeing this cardiac silhouette increased on either side, giving a money bag appearance or leather bottle appearance. And what do you think is the second radiograph showing you? What do you think is the second radiograph showing you? Can you appreciate there is a concave pulmonary area and an upward cardiac apex? The cardiac apex, instead of being downward, is directed more upwards. So this is called as Corin Sabot. Corin Sabot. This is boot-shaped heart. Boot-shaped heart. All of you are knowing this. This is tetralogy of Fallot. Very nice. Very nice. So tetralogy of Fallot. What about the third one? What do you think is the third one? Very good. Preeti, Tejasvi, Mithilesh, Rishabh. Right? Good. Sai, Aiza, Kawel. What about the third one? What do you think is the third one? What is the third one? Very good, Shrayesh, Dhaya. Third one. Tell me about the third one now. I hope you can see a classic figure of eight or snowman appearance of heart. Figure of eight or snowman, or also called as cottage loaf heart. Cottage loaf heart. This is feature of supracardiac type of TAPVC, right? Supracardiac type of TAPVC. This is figure of eight appearance of the heart. Nice. Let's move forward. Very good. Now look at this radiograph. Look at the cardiac silhouette. Is the right side increased or left side increased? Look at the left heart border. It is pretty much okay. The left heart border is pretty much fine. The right heart border appears to be going more towards right. There seems to be a right atrial enlargement. So such right heart border moving more towards right. This is suggestive of a right atrial enlargement, or also called as box-shaped heart. Box-shaped heart. And which condition you see box-shaped heart? This is feature of Epstein's anomaly. So if you see the cardiac silhouette increased on both sides, that is pericardial effusion. But if only the right side is moving more towards right, only there is right atrial enlargement, think of box-shaped heart, Epstein's anomaly. Epstein's anomaly. Fine. Now, let's move to the next one. Let's see some important GI images. Okay, we'll focus on GI radiology. We'll try to cover a lot of GI radiology in this session, the purely image-based session. Okay, so no, not much theory. We'll just try to label them one by one. What do you think is this barium study showing you? Is this barium, for the first image, what do you think is this image showing you? Is it a barium swallow, barium meal follow through, barium enema, or is it a enteroclysis? What do you think is this image? What is this first image showing you? Is it barium swallow, barium meal follow through, barium enema, or is it a enteroclysis image? I'm waiting for your answers. I hope you can see there is barium in the stomach, and also you can see the C-shaped loop of duodenum, right? You can see the C-shaped loop of duodenum. So when you see the stomach and duodenum, very good, Rishabh. When you see stomach and duodenum, this is barium meal. Remember, even duodenum is seen in barium meal, right? Duodenum is also seen in barium meal. But look at this image. Here, you are seeing the small intestinal loops. You can see the small intestinal loops. And if you observe carefully, if you look carefully, the small intestinal loops, the jejunal loops appear very feathery, right? So a lot of, feathery appearance is there because of the valvulae conniventis. The jejunal appears different from the ileal loops. So these are the ileal loops. They are featureless. So please remember, this is barium meal follow through. Barium meal follow through. And this barium meal follow through, the jejunum will show feathery appearance, and the ileum will be featureless because they don't have the valvulae conniventis. Jejunum has valvulae conniventis or plica circularis, and that is the reason the jejunum shows this feathery appearance on the barium meal follow through. Okay. Now, what do you think is this image? What do you think is this image? Look at the image given to you. What study is this? Is it barium meal follow through, barium enema, CT enteroclysis, MR enteroclysis? What do you want to answer this one? What do you want to answer this one? How is the bone? Bone is white, right? So it's a densely white bone you have here. So you know this is CT. This is CT. And here you can see a mucosal folds of the bubble, right? So there is distension of the bubble with mucosal folds. So this is CT enteroclysis. CT enteroclysis. We use a NJ tube in enteroclysis. We use a NJ tube and we use a double contrast. We distend the bubble loops and try to look at the mucosa better. So the mucosal lining is seen better in enteroclysis. So do differentiate enteroclysis from a barium meal follow through. Very different image. Let me show you once again. So barium meal follow through is a barium study, right? The lumen is seen. You don't see much of the mucosal rugae clearly, right? It's just the luminal opacification that happens. But in enteroclysis, there is distension of the bubble. The bubble is distended and the mucosa stand out. So that is how enteroclysis is. Now look at here again. This is again barium meal follow through. You can clearly see how jejunum is different from the ileal loops. Now let me see who can answer this. In which condition do you see jejunization of ileal loops? Look at the jejunum and the ileum. Look at the ileum. Instead of becoming featureless, it has become more feathery, like a jejunum. So there is jejunization of ileal loops. So in which condition do you see jejunization of ileal loops? In which condition do you see jejunization of ileal loops? Anybody? The ileum is appearing feathery with a lot of jejunization, jejunum-like appearance. Jejunization of ileal loops. Anybody has heard of this? Waiting for your answers. This is a condition. This occurs in patients with celiac disease. Do remember this, okay? Celiac disease, you will have jejunization of ileal loops. Normally, jejunum is feathery, ileum is featureless. But if you see jejunization of ileal loops, this is suggestive of the malabsorption syndrome, celiac disease, celiac disease. Okay, celiac disease. Now, let's come to the next one. Now, what do you think is this image is showing you? Is it barium enema, barium meal follow through, CT enteroclysis, or MR enteroclysis? What image is this showing you? Do you see bubble is distended? Yes or no? The bubble is distended. Do you see the mucosal rugae better? Are you able to see the mucosal rugae better? Yes, the mucosal rugae is also seen better. So when the bubble is distended, you see the mucosal rugae better. And how are the bones? Let us see the bones. The bones are, can you see the hip bones, right? The pelvic bones, they're all dark, right? You don't see any white bone here. And can you see the fluid signal also changing? T1 and T2. So these are T1 weighted image and these are T2 weighted image. We all know World War II, the water appears white on T2. Water appears white on T2. So these are MR enteroclysis. MR enteroclysis. This is MR enteroclysis. Let's move forward. What do you think is this study? What is this barium study? This is a showing small intestine or large intestine. This is showing large intestinal lobes. So this is barium enema. So this image is showing barium enema. What about this image? What is this barium enema study showing? This is also a barium enema. And what does this barium enema image show you? Which part is constricted? The rectal area is constricted. If you look at the sigmoid colon and compare it with the rectum, right? The rectosigmoid ratio is less than 1. The rectosigmoid ratio is less than 1. This must be suggestive of which one? Which condition? The rectosigmoid ratio less than 1. The rectum is much constricted than the sigmoid colon. This is Hirschsprung's disease. Hirschsprung's disease, right? Hirschsprung's disease. You have a rectosigmoid ratio less than 1. Very good. Very good. Now, let's come forward. Try to look at this question. What is this radiograph showing you? This abdominal radiograph in an elderly female with Parkinsonism. Elderly female with Parkinsonism is there, or a neurological disease is there, and you're seeing an abdominal radiograph. I hope all of you will answer this correctly. Can anybody tell me what is this showing you? What is this first image showing you? First radiograph showing you? What is this first radiograph? This is classic coffee bean appearance, sigmoid volvulus, right? So very nice. Sai, Meka Prasad, Mithilesh, right? So sigmoid volvulus, the coffee bean, right? In sigmoid volvulus, please appreciate no hostrations, No hostrations. And there are two loops that are seen. Two loops that are seen. You can see this is the one loop and this is the second loop that are seen, right? So this is sigmoid volvulus. What about this one? This is a young female with history of some pelvic surgery or pregnancies. And you are seeing a similar coffee bean appearance here. But if you observe carefully, you can see that this is having only one loop. And you can see these hostrations. And it appears like an embryo that is seen there. This is a cecal volvulus. Cecal volvulus. So cecal volvulus, you see hostrations. Hostrations are present. And you see only one loop. One loop. And generally, sigmoid volvulus are very common in elderly patients, and cecal volvulus are more common in young patients. Okay, so that is one thing. Sigmoid volvulus obviously will be associated with large bowel obstruction, whereas cecal volvulus, in front of cecum, what do we have? The ileal loops. So you will be associated with small bowel obstruction, right? So cecal volvulus will be associated with small bowel obstruction. Sigmoid volvulus will be associated with large bowel obstruction. That is easy. Let's look at some barium swallow images. Let me see how many barium swallow images you will get correctly. This is how a normal barium swallow image would be, right? Showing the esophagus. This is the esophagus. And here we all know this, a posterior outpoaching that you have. This is a Zenker's diverticulum, right? So posterior outpoaching that you see, this is in the neck, posterior midline. This is Zenker's diverticulum. And if it is an immunocompromised individual with odynophagia, and you are seeing so many irregular mucosal ulcers in the esophagus, giving a shaggy appearance of the esophagus, or cobblestone appearance of the esophagus. Cobblestone esophagus. Anybody? Which condition is this? Immunocompromised individual, right? And there is odynophagia in the patient. On the barium swallow image, you are seeing irregular mucosal ulcers in the esophagus, a shaggy esophagus, also called as cobblestone appearance of esophagus. Anybody? Where do you see such kind of appearance? Cobblestone appearance of esophagus. Waiting for your answers. Very nice, Rishabh. Rishabh is correct. This is cobblestone appearance or Candida esophagitis. Remember C for C. Cobblestone appearance in the intestine, right? In the bowel, that is Crohn's disease, right? So, but cobblestone appearance in the esophagus, especially classically given shaggy esophagus with irregular mucosal ulcers, immunocompromised, AIDS patient, right? Think of Candida esophagitis. Please remember this image. Please remember the description that comes to it. Immunocompromised individual, barium swallow image, the esophagus showing a cobblestone appearance or irregular mucosal ulcers. Think of Candida esophagitis. And where do you see large discrete ulcers in the mid-esophagus in AIDS patients? So you have large linear ulcers that are seen in the mid-esophagus. Where do you see, in which condition do you see this? In which condition do you see this? So AIDS patient and large linear ulcers, think of CMV esophagitis. CMV esophagitis also again occurs in immunocompromised individuals, right? So CMV esophagitis. Do remember CMV esophagitis has large ulcers, right? And superficial ulcers giving a shaggy esophagus appearance is Candida esophagitis. This I hope you all know. This is what is called as bird beak, also called rat tail appearance. Both bird beak and rat tail. This is achalasia cardia. Achalasia cardia. But this irregularity that you have, bird beaking with irregular shouldering, rat tailing with irregular shouldering, a rat tail appearance with irregular shouldering that you have. So you are seeing this shouldering with irregular rat tailing. So this shouldering that is said, this is CA esophagus. CA esophagus. So bird beak or rat tail appearance is achalasia cardia. A rat tail with irregular shouldering. This is CA esophagus. CA esophagus. Okay. Try to answer this thing. Where do you see this thing? Where do you see thin horizontal folds in the esophagus, especially the distal esophagus, called as a feline esophagus? Feline esophagus. Feline esophagus. Why are you telling? Okay, this one. Okay. I think you're answering the previous one. But what about this thing? In which condition do you see thin horizontal folds in the esophagus, especially the distal esophagus? giving a feline esophagus appearance. Feline esophagus. Which condition produces feline esophagus? In which condition do you get feline esophagus? Feline esophagus. Which condition? Feline esophagus is seen in which condition? So there are transient horizontal folds in the lower part of the esophagus. So it's like a esophageal shiver. This is also called as esophageal shiver. So it shivers, the esophagus shivers for a transient period of time. It's very transient folds. It's not permanent. This is just transient folds that you have. This occurs, this feline esophagus occurs when you have a reflux disease, gastroesophageal reflux disease, right? Or a hiatal hernia. So when you have a hiatal hernia or a gastroesophageal reflux disease, right, you will have this thin horizontal folds in the lower part of the esophagus. Transiently, when the reflux is happening, you get this thing. This is called as feline esophagus, feline esophagus. And look at this next one. There is a young male with asthma showing this multiple constrictions in the mid esophagus. Feline esophagus is in the distal esophagus. But here you are seeing it in the mid esophagus and you're seeing a constricted narrowing in the esophagus, giving a pseudotrachea appearance. Pseudotrachea appearance. Concentric rings giving a pseudotrachea appearance. Where do you see this? Very nice, Sana. This is feature of eosinophilic esophagitis. Eosinophilic esophagitis. You're already given history of atopy, asthma in the patient, right? Eosinophilic esophagitis. So do not confuse feline esophagus and the pseudotrachea appearance. These are two different conditions. Feline esophagus is transient, whereas these eosinophilic esophagitis, this is more permanent, right? These are constrictions that you're developing. So once again, feline esophagus is a transient mucosal folds that occur in the distal esophagus. They come and go away. That is esophageal shiver that happens because of the reflux that is happening. So gastroesophageal reflux disease produces feline esophagus. Eosinophilic esophagitis. People will have history of atopy, asthma, and you get constricted area in the esophagus, mid esophagus, giving concentric rings, the pseudotrachea appearance. That is eosinophilic esophagitis. Okay, let's come to the next one. Okay. What about this? Schatzki's ring would be in the lower part of the esophagus, right? So Schatzki's ring will be in the lower part of the esophagus. Look at here. You are seeing pooling of barium in the upper part of the esophagus, and you are seeing a mucosal fold in the upper part of the esophagus, especially from the anterior part of the esophagus. There is a mucosal fold causing pooling of barium in the upper part of the esophagus. This is esophageal webs. Esophageal web associated with Plummer-Vinson syndrome, right? So esophageal webs are present in the upper part of the esophagus. Schatzki's ring, similar mucosal ring, would be present in the lower part of esophagus. That would be Schatzki's ring. Esophageal web in the upper part of the esophagus associated with Plummer-Vinson syndrome. Okay. This is again CA esophagus. You can see the rat tail with irregular shouldering that you have. And this is the same image, the achalasia cardia, the bird beak appearance. Okay, let's move forward. What about this barium swallow images? Can you think about this thing? Where are you getting this crescentric narrowing of the esophagus? Crescentric narrowing of esophagus that you're getting. Right? So crescentric narrowing that you see in the esophagus. And you can sometimes see calcifications also. When you do a CT scan in this area, you may see calcification also. Anybody? What is this? A crescentric narrowing in the esophagus on a barium swallow image. Barium swallow image. Anybody can answer this? Crescentric narrowing of the esophagus. Calcifications are there on CT scan. What do you think this would be? This is esophageal leiomyoma. Right? So esophageal leiomyoma, they produce a crescentric narrowing of the esophagus. Okay, on a barium swallow study, you get a crescentric narrowing of the esophagus when you have a smooth muscle tumor, right? The common benign lesion of the esophagus that you have, esophageal leiomyoma, would produce such kind of appearance, right? Do not confuse it with cancer. Cancer would show that irregular shouldering, right, and narrowing of the esophagus. That is different. Leiomyoma is different. Okay, please be careful with this. Okay, where do you see such retrocardiac air fluid level? In which condition do you see such retrocardiac air fluid level? This retrocardiac air fluid level on chest X-ray, this is feature of hiatal hernia. Hiatal hernia. So when the stomach, right, herniates into the cracks, you get this retrocardiac air fluid level on the chest X-ray, right? So that is how you have your hiatal hernia, or a sliding hernia. Both images are the same. Okay. What is this herniation of bubble loops that you see on the left hemithorax? All of you know this. This is congenital diaphragmatic hernia. Diaphragmatic hernia. Please remember, because it is on the left side, this is Bogdalex. This is most common, right? The more common type of congenital diaphragmatic hernia is Bogdalex. What about this one? There are also herniation of bubble loops. There is herniation of bubble loops in the right medial hemithorax. This is the right side. This is on the right side and on the medial part of the right hemithorax, right? The right medial hemithorax. This is also congenital diaphragmatic hernia, but this is Morgagnis. Morgagnis. Morgagnis, right? Right. Morgagnis is right anteromedial. Anteromedial. Whereas Bogdalex is left posterolateral. Left posterolateral. That is how you look at the images and tell this is Bogdalex and the Morgagnis hernia. Okay. Look at the next one. Look at the next one. There is a coiling of nasogastric tube, right? In a newborn with frothing. There is a neonate with frothing. And a barium swallow study is also showing you the contrast, the barium entering into the trachea also, the trachea and the tracheal tree. So what do you think is this condition? This is trachoesophageal fistula. So either a radiograph may be given, or they can give you the barium study showing the opacification or contrast entering into the tracheal tree. This is trachoesophageal fistula. Trachoesophageal fistula. Remember both the images, how trachoesophageal fistula will appear on the radiographs and on the barium study, right? Next one. Okay. Try to answer this one. This had appeared in the recent examinations also. There is a young female with emotional problems and a CT scan is given. You can see the bones are white. So this is CT that is given to you. Anybody? Let me see who can answer this. What do you think is this? Waiting for your answers. What do you see on the CT scan here? You can see a distended stomach, right? With lot of heterogeneous areas within, lot of, heterogeneous areas with a distended stomach. Very nice, Keval, Nikki. Very good, very good. You are seeing a grossly distended stomach with heterogeneous opacities in the stomach. This is trichobazole, right? So very good, Sana, Rishabh, Nikki, Keval, right? You guys got it wrong. Mega, right? Nice. What is this one? What is this abdominal radiograph showing you? There are distended bowel loops in the abdominal radiograph. Some obstruction is there. And what else do you see? You can see a foreign body in the rectum. So rectum is a common site for foreign body, right? So you can see a foreign body in the rectum, right? So these you should be able to pick up. Okay, let's see the next one. This is a person who's brought to the medical care while having complaining of abdominal pain at the airport, right? He's complaining of the abdominal pain at the airport and he's brought to the medical checkup. And this is what you see on the radiograph, abdominal radiograph. What do you think is this? What do you think is this image showing you, this abdominal radiograph? This person is having abdominal pain. He was brought from the airport because he started complaining of abdominal pain. And what do you see on this radiograph? Anybody? Anybody can guess it? The first image, the first radiograph. Very good, Rishabh. You are seeing this is a body packer. This is a body packer, right? So latex bags are there, which are containing the drugs, and these are all filled up in his intestine. You can see them there here. Okay, this is a body packer, okay, smuggler who is carrying these latex bags containing the drugs within him, right? So this is how the body packers would appear. And what is this sign showing you? What is this thing? This is hollow viscous perforation. Hollow viscous perforation. This is called football sign. Football sign. Or you can also see the inverted V sign. Inverted V sign of hollow viscous perforation or pneumoperitoneum. What about this radiograph? So this is how we have pneumoperitoneum. What is the third radiograph showing you? Can you think about third radiograph? What is this third radiograph showing you? Do you see distended bowel loops? Do you see distended bowel loops? Yes. Are they in the center or in the periphery? They are in the center. Are they lying one above the other? Are they giving a step ladder pattern? Yes, they are one above the other. So this is which obstruction? Small bowel obstruction or large bowel obstruction? This is small bowel obstruction. They are central loops. They are having a step ladder pattern. And which part of the small bowel do you think is obstructed? Is it jejunal obstruction or ileal obstruction? What do you think is this? Is it jejunal obstruction or ileal obstruction? Look at the radiograph carefully. You are seeing these mucosal folds running through and through the bowel wall. There is circular mucosal folds running through and through the bowel wall, giving what is called as a the plica circularis or volvulae conjumentis on the radiograph. So this is jejunal obstruction. Jejunal obstruction. Right, jejunal, very good cable, right? So that is how we diagnose jejunal obstruction, a small bowel obstruction. Okay, what are these images? What do you call this technique? Ultrasound technique. This is an ultrasound technique which is showing you the anterior chamber of the eye. You can see the cornea, the anterior chamber, the iris, the anterior chamber of eye, anterior chamber of the eye is shown on ultrasound. What is this technique called? It's not a B mode actually. You give another name called as ultrasound biomicroscopy. Biomicroscopy. So this technique to evaluate the anterior chamber of the eye using a high frequency probe. This is called ultrasound biomicroscopy. You see the anterior chamber of the eye. Okay, only the anterior chamber of the eye is visible. This is ultrasound biomicroscopy. And where do you see this double bleb sign? Double bleb sign having two small bubbles there. One is made up of amnion and the other is made up of yolk sac. Amnion and yolk sac. What do you think is this? This is true gestational sac. True gestational sac. Right? A true gestational sac will show you this double bleb sign made up of two blebs, amnion and yolk sac. And this is a pregnant female complaining that she is not able to feel the fetal movements for the past few days. And here on the image, you see overlapping of sutural bones. You can see this is overlapping of sutural bones. This is called Spalding sign. Spalding sign. And Spalding sign is suggestive of what? Intrauterine death. Intrauterine death. Then, okay, look at here. What is this? This is a thyroid ultrasound, right? This is normal scrotal ultrasound. This is cholelithiasis, right? Cholelithiasis. They're all simple images that you all know. Just trying to, show you those important images that can come in the exam. So thyroid ultrasound, right? How the right lobe and left lobe of thyroid. And this is the isthmus of thyroid that you have. Let me see if you can answer this one. What is this technique that is being done here? What is this ultrasound technique being done here? What is this ultrasound technique here? Anybody? What is the first ultrasound image showing you? What is this ultrasound technique showing you? There are some color coding, some hard areas which are blue color, some soft areas which are red color, some yellow color areas are there, some intermediate areas are there. What do you think is this technique of ultrasound that is being done? This is called as ultrasound elastography. Elastography. And this ultrasound elastography is basically used to look at stiffness of the tissue. Stiffness of tissue. So in the breast, in the breast lesion, you want to know which is the hard area, which is the soft area. There'll be a color coding given to you, okay, telling you which is hard area and soft area. That technique which looks at the stiffness of the tissue is called as ultrasound elastography. And this technique helps you to guide FNAC and biopsy. Guides FNAC and biopsy. You want to take a tissue sample. You don't want to take necrotic material, right? You don't want to put the needle in the necrotic area. It will not give you diagnosis. You want to put the needle into the tissue sample, right? And get a tissue sample. So from the hard area, you want to take a FNAC or biopsy. So to help you to guide FNACs and biopsies, when you're doing ultrasound guided FNAC, you use this ultrasound elastography to look at the stiffness of the area. Ultrasound elastography is also used in a technique called as fibroscan. Fibroscan. This is used in the liver to look at the progression of chronic liver disease into cirrhosis. The progression of chronic liver disease into cirrhosis that is given by fibroscan, right? So this technique is not a color Doppler ultrasound. Okay, please differentiate. This is a lesion in the breast, right? And you are seeing this color coding and you see this red color, yellow color, blue color areas. This is ultrasound elastography, not a color Doppler image. Okay, so please remember ultrasound elastography. Remember how ultrasound elastography appears, how ultrasound biomicroscopy appears. Okay, keep this in mind. Then, what are these things? What do you think is this image showing you? This is a spectral Doppler. This is a spectral Doppler. And what does this spectral Doppler show? Especially of the umbilical artery. Umbilical artery. And you are seeing a reversal of flow. Reversal. So you're seeing the wave pattern where you see reversal of diastolic flow. The diastolic flow reversal is seen. What is the management? Immediate termination should be done. Immediate termination. And what is this? This is color pickup in the blood vessels. This is how we have a color Doppler, right? So based on the frequency shift, we have the color Doppler. So this is how we have the different images: ultrasound elastography, spectral Doppler, and a color Doppler image. Let me show you one interesting GI image. What do you think is this image showing you? This is a patient complaining. This is a post-op patient complaining of abdominal pain. Abdominal pain. And a CT scan is given to you. A CT abdomen is given to you. And the pain is mainly at the post-op site. Abdominal pain at the post-op site. You have abdominal pain at the post-operative site and a CT abdomen is given. Let me see if you can answer. This will be the last one. It's a brief 25-minute session I wanted to have with you all. Just see if you can answer this correctly. What do you see on this CT scan image? A post-op patient with abdominal pain at the post-operative site. A CT abdomen is given. What do you think is this? What do you think is this? Waiting for your answers. Let me see. What do you see on the image? Can you see within the CT abdomen? Can you see this heterogeneous intraperitoneal area? Right? In the intraperitoneal area, you see a heterogeneous mass showing lot of mottled air, right? And also some linear calcifications that you have. So there is a mottled air, some linear calcification, intraperitoneal lesion in a post-operative patient. Think of anybody? I didn't get an answer yet. What do you call that? Cable. What do you call that? Some kind of fibrosis. Okay. Exactly what is that name called? This is a cotton swab that is left behind, right, at the post-operative time. So you see that heterogeneous air, linear calcifications. So when you see intraperitoneal mass, right, there is intraperitoneal collection, which is having heterogeneous opacities, right, some linear calcifications within. This is, what do you call that? Gossipyboma, right? So this is gossipyboma, right? So please remember this important thing also. So foreign particle, basically you forgot the gauze piece at the operative site and the patient is having chronic pain in the abdomen at the post-op site, and you get a CT scan done, you see this heterogeneous mass, right? So this is gossipyboma. I hope you'll not miss this in the exam. So trichobazor is important, gossipyboma is important, then the other ones are fine. I think this much should be fine for the small session that we wanted to do, and especially my focus was on GI radiology. Thank you for taking active part, and I hope these IBQ sprint series are helping you. By the way, can you just tell me this one, this radiograph? This is popcorn appearance on chest X-ray. This is pulmonary hematoma. Pulmonary hematoma. What about this one? What do you think is this? This first radiograph. This irregular calcification spreading across the lobes. This is upper lobe, this is lower lobe of the left lung. It is going beyond the lobe. So it is not in the lungs, right? It is in the pleura. Such irregular calcifications in the pleura. What do you call this? This is holly leaf sign. This is holly leaf sign. Where do you see such holly leaf sign? Holly leaf sign is feature of asbestosis, pleural calcifications. Basically, these are pleural calcification. Why do you say pleural? Because if it was lobar calcification, they would be limited to one lobe. Either they would be in upper lobe or in the lower lobe. But here the calcifications are irregular and they're extending beyond the lobes, right? So they are extending beyond the lobes, upper lobe and lower lobe. It is extending beyond the lobes. So it is not in any lobe particularly, it is in the pleura. So these are pleural calcifications. These are called as holly leaf sign, feature of asbestosis. Lastly, there is a congestive heart failure patient. You can see there is a cardiomegaly, basal congestions, and you see a lentiform collection at the physeal lines between the middle lobe and lower lobe, or between the upper lobe and middle lobe, between the left upper lobe, left lower lobe, at the physeal lines in the interlobar areas. You see this lentiform collection. You can see physeal thickening also that you are having. So all of this is suggestive of interlobar effusion. Interlobar effusion. What do you also call this? This is also called as phantom tumor. Phantom tumor, right? It disappears after giving diuretics, right? So these are all the important images that I wanted you to understand. Gossypiboma is important. Trichobezoar we did, right? Trichobezoar is important. We also understood how a body factor is, right? And our trichobezoar is, right? Thank you so much for your active participation. There are some really good image-based sessions planned out on the YouTube of DocTutorials. Keep following it up. It will be brief sessions and something which is very high yield, and a lot of image-based discussions as of different subjects will be done. So hope you all actively take part and hope you enjoyed the sessions. Okay. Thank you so much and stay connected. Okay. Take care, guys.